Assalamu alaikum. Dr. Mujahid, can you hear me?
Walaikum Assalam. Yes, I can hear you.
वालेकुम सलाम।
कैसे हैं आप ठीक हैं?
Alhamdulillah.
जी, बिल्कुल अल्लाह का
Okay,
शुक्र है।
now we can
थैंक
see you as well. It's nice to see you.
Thank you very much.
Assalamu alaikum. I welcome you all in today's PSA Karachi online lecture series. I'm Dr. Azhar Rahman, working as a consultant anesthesiologist at Aga Khan University, Karachi. Today's topic is very interesting and very useful from practical, clinical, and from examination point of view. The topic is an inadvertent perioperative hypothermia. Is it important? And the speaker is Dr. Mujahid Ul Islam. After graduating from AU Medical College in the year 2001, he did residency from Aga Khan University Hospital, Karachi, Pakistan, and he secured the Best Graduating Resident Award in the year 2008. His area of expertise includes cardiothoracic anesthesia with a focus on critical care. He has authored several research papers which he presented at different medical conferences. He's also holding the position of PSA Vice President, KPK chapter. Currently, Dr. Mujahid Ul Islam is working as a professor of anesthesiology and critical care and head of the department at Rahman Medical Institute and College, Peshawar. He's also a supervisor of CPSP in the field of anesthesiology and cardiothoracic anesthesia. So before we proceed, there are some instructions for the listeners. It is requested to all listeners to please keep your microphones on mute mode. If you have any question, write down in the chat box. And at the end of the lecture, feedback form link will be shared, which you have to submit to get your e-certificate. So, Dr. Mujahid, forum is now for you. Please start.
Dr. Azhar, shall I start or shall I wait for more participants?
I think, okay, yeah, we will wait for another 3 minutes. So we'll start
Okay.
at 7:35.
That's fine.
Yes, Dr. Mujahid, you can start now.
Bismillahirrahmanirrahim. Good evening, everyone. Thank you, PSA Karachi, for giving me this opportunity to talk about an important topic in anesthesia practice, inadvertent perioperative hypothermia. Is it important? Body core temperature is one of primary vital signs, along with blood pressure, heart rate, and respiratory rate. And perioperative temperature monitoring is recommended by every. Excuse me.
Yeah, I will request all the listeners to please put your microphone on mute mode.
Body core temperature is one of the primary vital signs, along with heart rate, blood pressure, and respiratory rate. And perioperative temperature monitoring is recommended by every anesthesia society across the globe. But unfortunately, temperature monitoring is the most neglected and underutilized monitor as well. Inadvertent perioperative hypothermia is an unintended decrease in the core body temperature of patients, and IPH has many proven and documented complications. I have no conflict of interest to declare for this particular presentation. A roadmap for my this presentation will be after introduction. I will talk about who should be monitored and what are the different sides of monitoring body temperature. We'll discuss normal thermoregulation and effects of general anesthesia, regional anesthesia, and general plus regional anesthesia on thermoregulation. Then I will go through IPH, its causes, its consequences, its prevention, and its management. And finally, I will share some important points of NICE guidelines. To highlight the issue of not monitoring perioperative temperature, I would like to share a recent survey conducted in Turkey. 200 anesthesiologists were included in the study who actively work in operating rooms. Of 200, 41.5% were specialists, 36% were research assistants, and 22.5% were academic staff. The average experience of anesthesia was between 5 and 8 years. Only 5.5% performed routine temperature monitoring for each patient. And the most frequent monitoring was performed in cardiovascular surgery with a rate of 87.5%. This was followed by pediatric patients, 25.4%, major surgeries, 19.3%, and surgeries longer than 30 minutes, 14%. Geriatric patients were monitored with a rate of 6.5%. To detect hypothermia, if you don't look for it, you will never find it. Normal body temperature is 36.5 to 37.3 degrees centigrade, and perioperative hypothermia is core temperature of less than 36 degrees centigrade. And perioperative hypothermia is defined as 1 hour pre-op, intraoperative, and 24 hours after the operation. Mild hypothermia is 32.2 degrees centigrade to 35 degrees centigrade. Moderate hypothermia is from 28 to 32.2 degrees centigrade. Severe hypothermia is less than 28 degrees centigrade. Temperature monitoring should be done in patients having general anesthesia lasting more than 30 minutes, major surgeries with neuraxial anesthesia, or when clinically significant changes in temperature are intended, anticipated, or suspected according to ASA and other societies. Temperature monitoring is not typically necessary during mild or moderate sedation, or if a peripheral nerve block is used without general anesthesia, because the thermoregulatory control is well maintained in these circumstances. Regarding temperature monitoring sites, nasopharynx, distal esophagus, tympanic membrane with a thermocouple, sublingual fossa, or pulmonary artery are used as core body temperature monitoring sites. In some circumstances, it is necessary to use an alternative temperature monitoring site, for example, axillary, bladder, forehead during general anesthesia with a face mask or supraglottic airway. During neuroaxial anesthesia or during certain surgical procedures, such as oral or esophageal surgeries. Thermoregulation. Thermoregulation is a homeostatic mechanism that aims to maintain a constant core body temperature. Hypothalamus receives neural input from all thermoreceptors located in hypothalamus, brain, spinal cord, skin, deep thoracoabdominal tissues, and initiates thermoregulatory responses if core temperature does move outside the limits of the inter-threshold range. We will shortly discuss this inter-threshold range. Now, this is an important slide. Inter-threshold range is the range of temperature between when the patient starts vasoconstriction and sweating. So usually it is 37 degree plus minus 0.2 degrees centigrade. When the patient becomes cold, an awake patient, he vasoconstrict, and 1 degree centigrade below vasoconstriction, he starts shivering. And once the patient is temperature is above 37.2 degrees centigrade, he starts sweating. And sweating activates active precapillary vasodilation. And in that way, it dissipates heat to the atmosphere. So this inter-threshold range is disturbed with anesthesia, especially in general anesthesia or general anesthesia with regional anesthesia. So this inter-threshold range is increased from 37 degrees centigrade plus minus 2 to, in cold temperatures, it goes down up to 2.5 degrees centigrade. And in warm, it slightly increases, and it increases from 37 to 38.3 degrees centigrade. So it means under anesthesia, the inter-threshold range is way below the normal ranges, and vasoconstriction will not be activated till the patient is fairly hypothermic. Now this is a patient who is in hospital. You can see his core body temperature is 37 degrees centigrade, and the peripheries, including upper limb and the lower limb, are slightly colder, and it is between 31 to 35 degrees centigrade. But once this patient is anesthetized, the patient vasodilates, and there is redistribution of heat from the central warm compartments to the periphery, and the core temperature drops from 37 to 36, and the peripheral temperature actually increases. The total mass of energy remains the same, but it is the redistribution of the heat from the warm central compartments to colder peripheral compartments. Now, this is a triphasic model of hypothermia intraoperatively. In the phase 1, there is redistribution of the heat, as already discussed, and it usually lasts for an hour. And after 1 hour, there is heat loss is more than the heat production, and it usually lasts for next 2 to 3 hours. And then there is a plateau phase when vasoconstriction sets in and heat loss is equal to heat production. Again, this is a triphasic model of intraoperative hypothermia. And here we are seeing that different types of anesthesia have different impact on temperature. For spinal and epidural anesthesia, the drop in temperature is less as compared to general anesthesia, because the thermoregulatory responses of upper body are intact, while in general anesthesia, after second phase, there is activation of the thermoregulatory responses and the patient vasoconstrict, and there is the heat loss is equal to the heat production. But if the patient is receiving combined general and regional anesthesia, the thermoregulatory response is not activated, and generally there is no plateau phase. Now, these are the different mechanisms of heat loss during surgery, well known to all of us, the four mechanisms: that radiation, convection, conduction, and evaporation. Of these, radiation is most significant and accounts for 60% of total heat loss. And the radiation is emitted in the form of infrared rays, a type of electromagnetic wave. Heat from core body tissues is transported in blood to subcutaneous vessels, where heat is lost to the environment through radiation. This manner of heat loss is the basis of familiar technology used to sense and identify the locations of persons in buildings who are out of normal view. Radiation is the major source of heat loss in most surgical patients as well. Conduction refers to loss of kinetic energy from molecular motion in skin tissues to surrounding air. When warm air or water are moved away from the skin surface by currents, this process is called convection. This accounts for the cooling effect of wind and laminar airflow in many surgical theaters. Conduction and convection account for 15% of the body heat loss. And evaporation accounts for 22% of the heat loss, as energy in the form of heat is consumed during the vaporization of water. Water evaporates from the body even when not sweating, but mechanisms that enhance sweating increase evaporation. Almost incidence of IPH is almost 100% if the patients are unwarmed, and results from combination of anesthesia-induced thermoregulatory impairment, cool operating room ambient temperatures, and exposure of open body cavities during certain surgical procedures. Earlier studies of intraoperative hypothermia found the incidence ranged from 50 to 90%, but recently the incidence is reported from 17 to 54% in different types of surgeries. In actively warmed patients with forced warm blankets, the mean lowest core temperature during the first hour was 35.7 plus minus 0.6 degrees centigrade. 64% of the patients reached the core temperature threshold of less than 36 degrees centigrade 45 minutes after induction, mainly contributing to the redistribution of the heat. And 29% reached a core temperature threshold of less than 35.5 degrees centigrade. Consequences of inadvertent perioperative hypothermia. Most cellular functions are dependent upon temperature, and hypothermia also provokes systemic responses. Thus, even mild hypothermia of 1 to 2 degrees centigrade reduction in the core temperature may have adverse consequences in the form of wound infections, coagulopathy, prolonged drug action, myocardial morbidity, shivering, and prolonged recovery time. Before I discuss these different consequences of hypothermia, I want to discuss this important trial, and I will be mentioning this trial in my upcoming slides. This trial was done in China and America, recently published 2022, and the aggressive intraoperative warming versus routine thermal management during non-cardiac surgery. PROTECT trial, a multi-center parallel group superiority trial done in 22 different sites in China and Cleveland Clinic from March 2017 to March 2021. Patients were randomly assigned to receive either aggressive warming to a target core temperature of 37 degrees centigrade, aggressively warmed group, or routine thermal management to a target of 35.5 degrees centigrade, routine thermal management group. during non-cardiac surgery. And randomization was stratified by site with computer-generated randomly sized blocks. Eligible patients aged more than 45 years had at least one cardiovascular risk factor, were scheduled for inpatient non-cardiac surgery expected to last 2 to 6 hours with general anesthesia. 5,013 patients were included. Outcome. Patients assigned to aggressive warming had a mean intraoperative core temperature of 37.1 degrees centigrade, whereas the routine thermal management group averaged 35.6 degrees centigrade. At least one of the primary outcome components, myocardial injury after non-cardiac surgery, cardiac arrest, or mortality occurred in 246, 9.9% of 2,497 patients in the aggressively warmed group, and in 239, 9.6% of 2,490 patients in the routine thermal management group. In conclusion, the incidence of a 30-day composite of major cardiovascular outcomes did not differ significantly in patients randomized to 35.5 degrees centigrade and to 37 degrees centigrade, at least over a 1.5 degrees centigrade range from very mild hypothermia to full normothermia. There was no evidence that any major outcome varied. Keeping core temperature at least 35.5 degrees centigrade in surgical patients appears sufficient. Impaired wound healing is triggered by thermoregulatory vasoconstriction, which decreases subcutaneous oxygen tension. Reduced levels of oxygen in tissue impair oxidative killing by neutrophils and decrease the strength of the healing wound by reducing the deposition of collagen. Hypothermia also directly impairs immune function. In 1996, Kurz et al. Conducted this landmark study in 400 patients. They actually divided 400 patients into 200 patients in two groups. One group at ambient temperature and other receiving forced warm air and fluid warmers in colorectal surgery. Study was stopped after investigating 200 patients because incidence of wound infection was 3 times more in hypothermic group, and days to first solid food, days to suture removal, days of hospitalization was also statistically significant in hypothermic group. And this study is mainly used in the development of guidelines and protocols for the management of the perioperative hypothermia. However, in PROTECT trial, maintaining target control temperature at 35.5 degrees centigrade was not associated with increased serious or superficial infections compared with maintaining target temperature at 37 degrees centigrade. Hypothermia causes coagulopathy primarily due to reversible impairment of platelet aggregation by reduced release of thromboxane A3, which impairs formation of an initial platelet plug. Hypothermia also reduces the activity of enzymes in the coagulation cascade, which in turn reduces clot formation. The combination of platelet and enzyme impairment typically increases perioperative blood loss and the need for transfusion. In 2008, Raja Gopalan, in their meta-analysis, found that even mild hypothermia of less than 1 degree centigrade significantly increases blood loss by approximately 16%, 4 to 26%, and increases the relative risk of transfusion by approximately 22%. Maintaining perioperative normothermia reduces blood loss and transfusion requirement by clinically important amounts. However, PROTECT trial, not included in the meta-analysis, found that transfusion requirements were nearly identical in patients randomized to 35.5 or 37 degrees centigrade. It means that if the core body temperature is between 35.5 to 37 degrees centigrade, the blood requirement was same. The effect of hypothermia on drug duration is that the neuromuscular blocking agents, opioids, and propofol duration is increased, and hypothermia also decreases the MAC. Regarding myocardial morbidity, hypothermia results in sympathetic stimulation with augmentation of plasma norepinephrine concentration, and it increases norepinephrine concentration by approximately 700% at 1.3 degrees centigrade of hypothermia, with consequent increased metabolic rate and hypertension. However, in PROTECT trial, primary outcome of myocardial injury and a composite outcome of myocardial injury, non-fatal cardiac arrest, or all-cause mortality at 30 post-operative days were similar between the two groups. The shivering threshold, as I already told, is 1 degree below the vasoconstriction threshold. Vasoconstriction is effective even during anesthesia. Consequently, core temperature rarely decreases to 1 degree lower temperature necessary to reach the shivering threshold. Intraoperative shivering is rare for this reason, and because anesthesia impairs activation of thermoregulatory defenses, including shivering. By contrast, post-operative shivering is common in hypothermic patients when anesthesia is worn off and no longer prevents activation of thermoregulatory defenses, including shivering, and also hypothermia, delayed drug disposition, and delayed emergence in hypothermic patients. Influencing factors for IPH is colder room temperatures, prolonged surgeries, patients with better insulation in the form of fats have less chances of developing IPH, while the patients with low body mass index are more prone for IPH. The higher the assay status, the higher the incidence of IPH, and the increasing age also has got the higher incidence of IPH. But having said that, Sun et al. In their study evaluated esophageal temperatures in more than 58,000 adults having surgery lasting more than 60 minutes who were warmed with forced air, and found that even in actively warmed patients, hypothermia is routine during the first hour of anesthesia. After that, average core temperature progressively increases. So every patient receiving general anesthesia or regional anesthesia, and especially those patients who are receiving general anesthesia plus regional anesthesia, are at risk and all needs care to avoid hypothermia. Before I talk about pre-warming, I will first talk about a bear hugger. Bear hugger and its benefits. Bear hugger system is a convective temperature management system used to maintain patients' core body temperature perioperatively, and the bear hugger system consists of a reusable warming unit and a single-use disposable warming blankets of different sizes and different shapes. Pre-warming. Pre-warming is actually pre-warming is equal to prevention of hypothermia. Pre-warming is only effective way that prevents thermal redistribution and maintains core body temperature. It involves active warming systems that maintain a surface temperature above normal core body temperature, and the warmed hospital blankets are not considered as active pre-warming measure. Horn et al. Evaluated the performance of different durations of active preoperative skin surface warming to prevent perioperative hypothermia and postoperative shivering. They randomly assigned 200 patients scheduled for surgery of 30 to 90 minutes under general anesthesia to receive either passive insulation, which is shown here. And this is again the triphasic model of intraoperative hypothermia. And you can see the group which received only passive insulation has significantly low temperatures. And the other three groups received pre-warming for 10 minutes, 20 minutes, and 30 minutes. So there were significantly differences in changes of core temperature between the non-pre-warmed group and all the pre-warmed groups, but none between the three pre-warmed groups. So pre-warming of patients for only 10 to 20 minutes before general anesthesia mostly prevents hypothermia and reduces shivering. So where can pre-warming be done? Pre-warming can be done in the wards. It can be done in the pre-op holding areas. It can be done in the induction room. And if you have no facility in these particular areas, you can do pre-warming in the operating room while inducing the patient, as already mentioned in the Horn et al. Study, that pre-warming for 10 minutes is good enough. Now, fluid warmers. Fluid warming does not significantly warm patients because intravenous fluids can only slightly exceed core temperature. Thus, fluid warming does not compensate for initial hypothermia due to redistribution from core to peripheral tissues, nor for subsequent losses from skin surface and surgical incisions. Similarly, warming of irrigation fluids used in the peritoneal cavity does not transfer meaningful amounts of heat to the patient, but patients can be cooled considerably by infusion of unwarmed IV fluids or exposure to unwarmed peritoneal irrigation fluid. For example, each liter of fluid infused at ambient temperature reduces mean body temperature by 0.25 degrees centigrade in a 70 kg patient, and a unit of refrigerated blood also reduces mean body temperature by 0.25 degrees centigrade. Therefore, infusion warming should be used for fluids if they are more than 500 ml, or fluid if we are giving fluids at a rate of 500 ml per hour or more. And we all know that usually we give more than that in our patients. This is another study done by John et al., and they compared the effect of delivering fluid warmed using two methods in 76 patients having short duration surgery. All patients received a liter of crystalloid delivered either at room temperature, warmed using an inline warming device, or pre-warmed in a warming cabinet for at least 8 hours, and found that pre-warmed fluid administered within 30 minutes of its removal from a warming cabinet is as efficient at preventing perioperative hypothermia as that delivered through an inline warming system. Gillian Campbell in 2015 in their systematic review of warming of intravenous and irrigation fluids for preventing inadvertent perioperative hypothermia found that warmed intravenous fluids kept the core temperature of study participants about half a degree warmer than that of participants given room temperature intravenous fluids at 30, 60, 90, and 120 minutes, and at the end of surgery. Warmed intravenous fluids also further reduced the risk of shivering compared with room temperature intravenous fluids. Passive insulation. A single layer of cotton blanket reduced heat loss in a typical operating room environment by approximately 30%, and 3 layers reduced heat loss by 50%. It made little difference whether the blankets were at ambient temperature or warm in an oven before application. Both 30% and 50% reductions are clinically important, but far less effective than active surface warming, because active surface warming preoperatively reduce the heat loss through the redistribution, and also intraoperatively active surface warming is more efficient. Balki et al. In their meta-analysis published 2020, active body surface warming system to maintain normothermia was associated with reduced risk for shivering, wound infections, and blood transfusions as compared with non-active warming controls. So active body surface warming systems are better in reducing these side effects. What are other methods for managing and preventing intraoperative hypothermia? First is the respiratory gas warming. The heat capacity of air is low, as we all know, and the heat of vaporization required to humidify dry gases is higher, but still low compared with the metabolic rate of patients. Consequently, little metabolic heat is lost through the airway, and airway heating and humidification does not transfer clinically important amounts of heat into patients, but does help in preventing heat loss. Endovascular heat exchange catheters. These invasive endovascular heat exchange catheters transfer far more heat than surface systems. Their use has been limited to establishing rapid and deliberate therapeutic hypothermia and normothermia in neurosurgical patients because they are invasive and expensive, and their use in clinical practice is far less than other methods. Surgical humidification system. Surgical humidification system or HumiGuard used warmed, humidified carbon dioxide actively diffuses into the surgical wound and abdomen via sterilized carbon dioxide diffuser, which is placed over the abdominal cavity. And as carbon dioxide gas is denser than air, warm and humidified carbon dioxide fills the abdominal cavity, displacing the cold room air into the atmosphere. Carbon dioxide warms the peritoneum, abdominal organs, and surgical wound, maintaining their integrity and function. And finally, these are the warming matrices which can be used to prevent hypothermia. Now I will share with you the NICE guidelines, which were initially published in 2008 and then updated in December 2016. And their main points before surgery are that one should identify patients at high risk of inadvertent perioperative hypothermia, and the high-risk patients are ASA grade 2 to 5. The higher, as we all know, the higher the grade, the greater the risk. And the patients who have a preoperative temperature of less than 36 degrees centigrade and they have preoperative warming is not possible because of clinical urgency. And patients who are undergoing combined general and regional anesthesia, and patients who are undergoing major or intermediate surgery and at risk of cardiovascular complications, and patients with low body mass index. It's not working. Dr. Azhar, suddenly my presentation, suddenly this, it's not working somehow.
Your slides are not working?
Yes, just wait a minute. Okay. As we already discussed, the high-risk patients, so active warming should be started before operation in hypothermic or high-risk patients. One should measure the patient's core temperature, and patients should not be transferred to theater unless their core temperature is above 36 degrees centigrade. Patients should be encouraged to walk to theater whenever possible. This increases heat generated by metabolism. During anesthesia and surgery, the induction of anesthesia should not be started until the patient's core temperature is more than 36 degrees centigrade or unless it is clinically urgent. Active warming is recommended for all high-risk patients, regardless of the length of the procedure, and for all patients with total anesthesia time more than 30 minutes. Forced air warmer is the recommended device. The temperature setting should be set at maximum and then adjusted to maintain a patient temperature of at least 36.5 degrees centigrade. Ambient temperature should be more than 21 degrees centigrade while the patient is exposed to reduced heat loss by convection and radiation. Thereafter, ambient temperature can be reduced for staff comfort. Equipment to cool the surgical team should also be considered. Warming, regarding warming IV fluids, use a continuous fluid warmer incorporated into the giving set. Pre-warm fluids are as effective if given within 30 minutes of removal from warming cabinet. Humidification of respiratory gases, although only a small amount of metabolic heat loss occurs through the respiratory tract, the use of a heat moisture exchanger filter or alternative humidification device is recommended. The patient's temperature should be measured at least every 30 minutes and active warming titrated to effect. This is useful to monitor for both hypothermia and hyperthermia. And this includes patients having regional techniques as well. After surgery, the core temperature should be measured with the observation in post-anesthesia care unit on admission and then every 15 minutes. Forced air warming should be continued if the patient is hypothermic. Warm blankets offer comfort but do not actively warm the patient. The patient should stay in post-anesthesia care unit until the core temperature is above 36 degrees centigrade. Patients should be kept comfortably warm for 24 hours after surgery with a duvet and blankets. So what is the summary of this whole presentation? So inadvertent perioperative hypothermia is detrimental to patient outcome. Measure your patient's temperature. Intraoperative warming alone is insufficient to prevent IPH. Pre-warming should be used whenever possible. Even small volumes of unwarmed fluids can contribute to IPH. And there should be a continuous medical education and training for anesthesia people who are taking care of the patient, for awareness and for the implementation of the institutional protocols and guidelines to manage inadvertent perioperative hypothermia. Thank you very much.
Thank you, Dr. Mujahid. A very nice talk supported by the recent available evidences. If anyone has any question, please ask directly, or you can write it in the chat box. From clinical point of view, it's a very important topic, and from examination point of view as well. So please ask question if you have any query. Dr. Mujahid, one mechanism is if the patient is under regional anesthesia or under general anesthesia, active vasodilation that is responsible for the heat loss. So can we use vasoconstrictor agents prophylactically in case if hemodynamics are stable?
Actually, this vasoconstriction is from the hypothalamus, and it is specifically vasoconstricting those vessels which are supplying blood to the upper limb and the lower limb. So the heat loss and the heat redistribution to the upper limb and the lower limb is reduced. But when you are using vasoconstrictors, they are actually vasoconstricting all of your vascular system. That will benefit, but how much it will benefit, I don't know.
Thank you. Any other question?
Sir, this is Dr. Danish from Oman Royal Hospital. I would like to ask, like in thoracoabdominal surgeries, when most of this is exposed to the theater environment, so what would be the best method to keep the patient warm?
So as we the whole presentation is actually on this topic. So the best method is to pre-warm the patient for at least 10 minutes before, preferably before induction or at the time of induction. And then you can use different methods. You can use conductive warming systems like hypothermia. You can use this convective warming system. You can use passive insulation. You should use warmed IV fluids. HME filters should be used. At the time of induction, preferably the ambient temperature should be above 21 degrees centigrade. So these are the different methods through which you can prevent this perioperative hypothermia.
Hello.
Yes.
Dr. Mujahid sir, well done. Very nice lecture. I enjoyed. I think the anesthesia people should ask you more than one question. But I will ask you just one question, being an intensivist. What is the effect of the perioperative anesthesia when you are sending a sample for coagulation profile? Usually they are measured at room temperature. And the result, do you believe they are reliable to give you the result by the lab?
So if the patient is hypothermic intraoperatively, say the patient's temperature is 34 degrees centigrade, so the coagulation system, they will test these at 37 degrees centigrade. So those tests are not reliable.
Thank you.
Thank you. Dr. Mujahid, there is a question by M. Nassim Javed. He is asking how we will manage drug-induced hypothermia / shivering, especially if placed mesoprostral during C-section. So there is a little confusion among the listeners between the hypothermia and shivering. The two things are different from each other. So Dr. Mujahid, could you please throw some light on it?
So if the patient is hypothermic, you have to warm the patient. If the patient is having shivering, you can manage with pethidine and other drugs, but effective way to manage is to warm the patient. Preferably, the ideal temperature should be above 36.5 degrees centigrade.
There's a request by Jennifer Rose. She wants to see the summary slide again. If you could display it.
Dr. Azhar, can you see it?
No, not really.
Okay. Now can you see it?
Now, yeah, we can see it. Jennifer,
okay.
could you see it clearly? Okay, so there are a lot of comments no question but comments by the listeners. They've really liked it a lot. I would request you- Jennifer is saying she can't see it. This is we can see it clearly.
I would like to want to see the slide before summary.
Now I request. Yeah, please introduce yourself and please ask question.
Assalamu alaikum, sir. I am Dr. Mujahid Ul Islam from Benazir Hospital, Rawalpindi. I am final year PG. Sir, I have a question, sir. Just in the presentation, it was clearly mentioned by the sir that there is a heat loss during the intraoperative period. That is likely that happens. But in neurosurgery cases, we induce hypothermia. Leaving all the point is that there are complications of hypothermia. We all ignore sometimes we ignore these complications, but we induce hypothermia to decrease the cerebral metabolic rate, cerebral oxygen demand. And in that circumstances, what are the good options to maintain neuroanesthesia? What is the optimal temperature that we can maintain? Second question I have regarding pediatric anesthesia. What is the best way to manage the pediatric patients from hypothermia? Thank you, sir.
Regarding pediatric patients, I deliberately did not discuss the neonatal and infants and the pediatric patients because that is a separate whole topic. And regarding your neurosurgical patients, if you want to protect the brain and you are inducing a hypothermia, it should be according to the guidelines, but at the end of the procedure, you have to bring the patient to normal temperatures. That's why if in neurosurgical patients, they have tried this invasive endovascular catheters to induce hypothermia rapidly and then to bring the temperature normal to 37 degrees centigrade.
But, so one point, please. One point, sir, please. What about the drugs that we use, like it is pethidine, but that is not available in Pakistan? What are the most favorable drugs that we can use to prevent the shooting or hypothermia in the patients? In our setup, we don't have other options. We usually use the drugs.
You can use nalbuphine, you can use tramadol, you can use midazolam.
Okay, sir.
There are a couple of more questions. One question is by Dr. Saima Bangash. She wants to know hypothermia in peds and adults. How aggressively peds hypothermia should be corrected?
How aggressively hypothermia should be corrected, regardless of the age of the patient. And the extreme ages are more prone for hypothermia. So pediatric hypothermia, again, we have to normalize the temperature. So methods are the same, except for neonatal, there are some differences. Otherwise, you have to manage hypothermia. Yeah.
Zishan Javed, Syed Zishan Javed has a question. He has raised his hand. Please.
This is Dr. Zishan. Sir, it's really nice. Unfortunately, I joined late because of the time difference in Saudi Arabia.
I just want to say you can see these presentations and with description on the YouTube channel of PSA as well. This will be uploaded very soon.
Okay. I just had a small comment and just addition to, maybe you had told about it, but I will just add on that low flow anesthesia is one of the things which whenever it is available, the agent analyzer and you can monitor the agent concentration. Low flow anesthesia is also a factor by which you can indirectly prevent the heat loss, because it will just moisten the gases more than the normal one. Okay. And so it will passively just be a factor. One point, and the other point is that sometimes we are using fluid warmer. But unintentionally, we are missing one point, that try to avoid too much extension out away from the distal end of the warmer. Okay, because a number of times we have attached the warmer, and then after that, from the distal part of the warmer, there is so much extension that whatever uh, warmth we have got already, it becomes again cold, so it becomes useless. So these are just two comments or two.
Dr. Zishan, in addition to your comment about this fluid warmer, so especially if the rate of the fluid is low or less, then it is even more important that fluid warmer should be nearer to your peripheral cannulas or central line, whatever it is.
Yes, that's why sometimes fluid warmer does not become effective unless you have pre-warmed the fluid a little bit, because sometimes it's difficult, because extension, the patient is covered. So it was just I was just seeing it, and then I showed it to the technician. He was not understanding this thing, and then I have the drip. I just touch. I show it to him that how much different it is. So thank you very much. And low flow anesthesia also, because low flow anesthesia, even in Pakistan, where we don't have availability of agent analyzer in every hospital, but the places where it is, unfortunately, people are afraid of using flow less than 1 liters. Okay, but I will just use this forum to send a message that don't be afraid. If you have the agent analyzer and you have the good concept of how to use low flow anesthesia, this will also help in, because one of the factors will be, because other factors you will all cover, this factor will again remain. So you can cover this factor by using low flow anesthesia. Thank you, sir.
I'm sure wherever there is circle system is available, people are using the flow less than 2 liters. Otherwise, it's useless to use the circle system. So there is another question by Mariam Masood. Her question is, sir, I have a question. The question is, I want to ask that, can we transfuse blood products during hypothermia, and can we use any prophylactic drug to reduce shivering suspected while transfusion?
Intraoperatively?
Yeah.
If we are transfusing blood products intraoperatively and we are afraid of shivering, I don't know. I don't think we have to give any drug. We just have to warm the blood and give to the patient.
Yeah. So the take-home message is, then whenever there is shivering secondary due to hypothermia, we have to actively use the warming devices to bring the temperature within the normal range. But if the shivering is because of anxiety or some other reason, then we can go for the pharmacological intervention. Another question is about the difference between, she wants Adnan, okay, it's Adnan Khan. He wants to ask about the difference between the shivering from hypothermia and shivering in spinal anesthesia. Does they both are same, as body temperature in spinal is normal but patient feels shivering, and what could be the management for spinal shivering?
Again, you have to check the core body temperature. If the core body temperature is less than 36 degrees centigrade, you have to warm the patient. So even in the spinal and epidural anesthesia, the patient can become hypothermic. Their lower extremities will feel warm, but actually they will be losing heat from there.
Yeah, thank you. With this, we come to end of this presentation. We have PSA General Secretary with us. If you have any comment, please.
Thank you so much, Dr. Azhar, for coordinating the session today. Assalamu alaikum, Dr. Mujahid, and I also like to thank you again for giving us such an insightful lecture. I'm sorry I was not present in the beginning. I can see 2-3 more questions. I will try to get those downloaded, and I'll send it to you, and then we can actually send the answers on the emails to those who have asked the questions but could not get the answers of over here. So I'm really grateful to you, Dr. Mujahid, for joining us at this time and giving us the lecture. We also have Dr. Amin Khwaja, who's the ex-president, Pakistan Society of Anesthesiologists, and he has also been one of the pioneers of starting these online lectures. So I'm really grateful to him as well that he has also joined, and I would also like to have him on board for his closing remarks. Dr. Amin, can you hear me, please?
Yeah. Thank you very much. Thank you, Dr. Asma, and thank you, Dr. Mujahid. Dr. Mujahid is one of the senior anesthetists, and thank you, Dr. Mujahid, for sparing time to give the talk in this from the PSA platform. Honestly, this is a very important topic, and most of the anesthetists, especially our younger anesthetists, don't care of the hypothermia. So, and this is an examination question also. So, Dr. Mujahid has given a very compiled talk, and he has presented initially in a very good study starting from the Turkey. And you can, Dr. Mujahid, you can see the active participation and the more questions that shows the interest of our young colleagues, even our senior colleagues who have participated. So I'm really thankful to Dr. Asma. She has continued this trend of online lectures. And thank you, Dr. Mujahid, for sparing time from your busy schedule and giving a talk. Thank you very much, sir. Thank you very much.
Thank you, Dr. Amin. Thank you. Thank you, Dr. Asma, as well.
So with this, we are concluding our session. If any one of you have any other query which is left, because the time is up, so we would request you to kindly send the questions, and we will try to answer you on email, or we will forward you the relevant topics associated with this important topic. At the same time, I would also request every one of you to kindly fill in the feedback form so that you can get the e-certificates, especially for those who have joined us today as a first timer and who don't know the format of these lectures. So kindly fill in the feedback form so that you can get the e-certificate later on your email addresses. Thank you so much again, Dr. Mujahid, and thank you everyone for joining us tonight.
Thank you, Ji.
Thank you, Dr. Mujahid.
Thank you. Thank you, Dr. Azhar. Take care.
We'll see you again.